This is what I told you in assessment part. We have a problem. We don't do this assessment for a reason. We do it simply because your teacher will ask you to do, or the documentation of the patient needs an assessment. We know that the patient is a Parkinson's patient, and then only we do the assessment. But how it should be, you should take subjective assessment very seriously. You should ask enough questions to the patient. This subjective assessment should lead you to a hypothesis. Okay, the patient is having upper motor neuron lesion, well and good, but where is the location of lesion? Because where is the location of the lesion will tell you how far the patient is going to progress. I told you that the presence of neuroglial cells can bring about a better prognosis in the patients if the problem is in the brain, particularly the cortex. The pure cortical problems resolve better. The subcortical problems resolve slightly better. The brainstem little bit less, spinal cord even more less, and the peripheral nerve system completely bad. So when I tell you that the hypothesis is very important, because it is going to tell where is the location of lesion. Tentatively you are going to ask the patient all subjective history, and you are going to frame a hypothesis, and this hypothesis you are going to test using your objective assessment. So what I was trying to say is, from the subjective examination, you should come to a tentative idea what might be the hypothesis. With the hypothesis, it's a tentative idea, it is an imaginary statement. You are going to confirm this hypothesis using your objective assessment. Got it? So it is like a police inspector goes and do investigation by seeking information from all the victims, and he will come to idea that this might be a problem of this, and then he will go and find evidences and collect evidences and document them and file that on the court. So it's more or less like that. Or even you can take a research process. You have a research problem, you collect information about the research problem, you have a hypothesis. That hypothesis you will do a research to know whether the hypothesis is true or wrong. This is nothing but a hypothesis driven assessment process. Here you are taking a lot of information from the subject. You are taking a lot of information based upon which you come to an idea, maybe his cerebellum is involved. Okay, so once you know that, once you think that his cerebellum is involved, you are going to confirm that the cerebellar lesion is the one which is causing all the trouble by means of his objective assessment. And subsequently, once the objective assessment is over, you are going to confirm it is a cerebellar lesion, and that is called as the physical diagnosis. Okay, this is how your assessment should be. Most often what happens, subjective assessment stands separately, objective assessment stands separately, and the treatment will be something else. Most often it is passive movements. Okay, so please don't do that. That is what I am explaining here. So the physical diagnosis, after the physical diagnosis, you will come to know what are all the problems. If you don't identify these problem list from your assessment, then your assessment is completely waste. Okay, once you assess the problem list, you are going to pace your goals, and once you pace your goals, you are going to go for the treatment plan. So very importantly, the order of priority of the treatment should come from the problem list. Which is the major problem for a physiotherapist here? That should be first, second, third. For example, if I have 3 problems, all the 3 problems should be coming in the goals. I should mention all the problems in the goals also, because if I have some problem and if I don't attest the problem in my goals, then the problem is not a big deal at all. For example, if I have weakness of the upper limb as my first problem, okay, and learning as a second problem, the patient do not have a proper learning of movements, and the third problem is balance, then I have to devise something to attest in the goals for the 3 things. And if I set that as a goal, I should attest them in the treatment. So what I'm trying to say is, you should have a flow of information from the problem list to the goals to the treatment. Now the physical diagnosis, problem list, goals and treatment should be in a sequence. So when you are appearing for an exam or when you are writing an assessment, don't have problem list, 10 problem list and goals attesting only 5 of the problem and treatment attesting only 3 of the problem. That is how most of my students do. I find them mistake in this place. Why you are not attesting this problem, I'll ask. So have a orderly sequence. Okay, nice. Now, the subjective assessment, you should have chief complaints. You should have this chief complaints. You should put open-ended questions to the patient. Like, do you have pain? That is a closed-ended question. The patient will say yes. So you cannot extract more information from the patient. You should ask, what is your problem? What do you expect from this treatment? What do you think you are suffering with? All these things are open-ended questions. Okay. So next is, you should have documentation of the chief complaint should be in a hierarchical manner. If a patient says, sir, my problem is I am not able to lift my hand up to reach out to objects, that should be our first problem list. Then they will patient say, I have pain when I am lifting up. Okay, so then pain becomes second. And then the patient will say, you have any other complaints? If you ask, sir, because of this I am not able to hold on to objects and I am not able to lift heavy weights, then that should be the third chief complaint. So it is more philosophical, like which is your most major problem. The patient will come out with that particular problem first. So order of recording is very important, and that order should be set by the patient, not the therapist. Next, it should be in patient language. Don't record any technical terminology in the chief complaints. If the patient says, I'm not able to lift my hand and reach the object, you should not document lack of shoulder flexion and elbow extension and elevation activities. So that should not be the thing. Chief complaint should be in the patient's language. Whatever he says, you have to reproduce here. Okay. If the patient says that I am having a sensation of burning all over my upper limb, you have to document that. Okay. So you should not say a vascular pattern of pain is present in the upper limb. Got it? So fourth important thing is duration should be mentioned. Any chief complaint should have the duration. Sir, I am not able to lift my hand and touch objects on the shelf for nearly 4 or 5 weeks. That's how people will normally say. So duration you should mention, because all these things give you a very good idea about what the patient is suffering with. Next, the subjective examination. Very importantly, the history taking. This is a very important thing if you are working in a neurological area in a hospital. You should not think all the patients coming to you are having neurological problem. More than this, you should know that all the patients coming with some complaints are patients. They may not be a patient also. They'll be coming with some psychological issues, which like sort of a pain. They think that there is having some pain, but there may not be any pain at all biologically. And moreover, don't think all patients as neurological. There may be some musculoskeletal problem also in that patient. This is a disclaimer. This was said by John Patton, whose book is a very significant contribution in the differential diagnosis of neurological conditions. Next is subjective assessment. First very important thing is, don't ask the patient immediately he enters into the clinic. Ask him, give some time to settle down. Okay, discuss how I develop relationship with patients. I will ask them, what is your name? They say, my name is Kumaran. So from where you are coming, Kumaran? He will say, I am coming from Chennai. Oh, great. My native is Chennai. I live in Chennai for nearly 20 years. So I relate him with that. If he says, no, I belong to Tanjavur. No, I was born in Tanjavur. Very good. Where you are coming from, Tanjavur? Likewise, in Tamil Nadu, if he says whatever place, I will relate him with my some or the other activity. If he says I am coming from Coimbatore, I will say, hey, I studied in Salem and Coimbatore only. Where you are coming from? So that bonding and the nativity you develop with them will help him in coming out with more information compared to just immediately after he coming in, you are asking him question, means that is going to be not develop that particular rapport between you and him. Okay, and then avoid repeatedly looking at the clock or any other areas diverting when the patient is saying. I have seen many therapists will the patient will be looking there, they'll be looking into their mobile. Nowadays, that's a very important thing people do with mobile. You keep on telling I'll look into my mobile, then the patient will not come out with the information. So you have to maintain the eye contact with the patient. That is very essential. If you want to confirm with the information of the patient, you have to use the third party, that is his caretaker. But make sure that you don't land up in trouble where they keep arguing on certain thing and you will just become a referee in that. Okay, that also happens. Sometimes direct questions will help you. I mean to say direct questions in the sense the patient will say, from yesterday night I have severe lack of sensation in my thighs and my lower limb. Bilaterally I'm having this problem. If you suspect the patient to have any problem during his sexual intercourse, or if you feel like he's having a sensory neuropathy, particularly diabetic sensory neuropathy, restrict him, restrict yourself in asking him question directly. Do you have any problem in your sexual life? If you have any problem in the erection problem, you should directly ask questions. There you can use the closed-ended questions. Fine, because most often, because of the social stigma and the resistance, patients will not come out with the real truth. So you have to ask them. Next is be specific with the symptoms. For example, if the patient says, "Sir, this weakness gradually came, sir." Gradually means what? Define it. Whether it is days, weeks, or month. Even if it is developing over a period of month, also they will say gradual. If it is year, also they will say gradual. So you should know what is number of days. So if it had developed within a given number of days, you can say it's a vascular problem. If it is developing over a period of months, you can say it is a tumor. If it is developing over years, you can say it can be myopathy or any neuropathy. So depending upon the duration, you can come to some conclusion about the differential diagnosis. There are some other direct questions you can ask the patient about the pain. If the pain has remember that in assessment of neurological conditions, you should have a pain history completely charted like a musculoskeletal problem in case the patient complains of pain. So previous medical history, if you have any specific details, if you want to ask, sir, are you taking Eptoin tablet? Are you taking Syndopa tablet? When you are taking? How long you have been taking? These direct questions, you may think that physiotherapists may not need these details and they may not tell you. And previous occupational history is very essential because that will give you a clear idea about what was the problem of the patient. The family history will give you clear idea about any genetic disorders which we saw in neuromuscular condition.